Good afternoon, everyone. On behalf of Dentium, I warmly welcome you all in this today's webinar on digital workflow. We are privileged to have with us our esteemed speaker, Dr. Avantika Tripathi, MDS in Oral and Maxillofacial Surgery, and our key opinion leader and mentor of Dentium. She will be sharing her valuable insights and clinical experiences on the digital workflows in the modern dentistry and also about Dentium Digital GuideKit. And we encourage all the participants to stay till the end of this session as we will be announcing some exciting offers exclusively for the webinar participants. And thank you for joining us again. Now over to Dr. Avantika.
Thank you, Mr. Subbaru, for the warm introduction. Good afternoon, everyone. It's a pleasure to welcome you all in today's webinar on digital workflow with the Dentium Digital GuideKit. In the next few minutes, we will explore how guided surgery is changing modern implant practice. Traditional implant placement depends heavily on operators' experience, but with the digital workflow, we can now plan virtually and execute precisely. So, firstly, I would like to start with what is digital workflow in implant dentistry. So, digital workflow is use of digital tools from the diagnosis to the final prosthesis. First of all, when we plan any implant surgical procedure, we get a CBCT done for the patient. We diagnose the case, we evaluate the bone in a CBCT, then we do the intraoral scanning. We combine the data of both and we get a planning done and we get a surgical guide fabricated. Once the planning of all the implant sizes, diameter, everything is done, we get the fabrication of surgical guide and we call the patient for the surgical procedure. In the surgical procedure, we follow the sequential drilling and we place the implant that we are going to discuss further. How is it done? Once the surgical procedure is complete, then we are going to put the prosthesis over it. The prosthesis procedure is also done digitally, planned digitally, designed digitally with the help of CAD and CAM. Now most of you will think why there is a requirement of moving beyond freehand surgery. Some doctors feel like I'm very, very confident enough in doing a freehand surgery. What is the requirement of doing a surgically guided implant placement? So sometimes we feel like our implant is properly angulated, but it is not. Because if we have done our 100%, there can be some sort of change in bucco-palatal orientation or a mesodistal orientation. There can be depth errors. An implant manually can be slightly deeply placed than a previously surgically guided planned implant placement. There can be anatomical risk, injury to the anatomical structures, like there are sinus, inferior alveolar canal is there. So there is a high risk of injuring all these anatomical structures. There can be a prosthetic compromise. There can be a case in which we end up compromising the prosthesis of the patient. But if we are going with the guided surgery, we are going for the ideal implant positioning. We are going for the controlled depth. We are providing better aesthetics to the patient. We are doing the surgery way faster because we are not going to raise any flap. We are doing a flapless surgery, and it is very, very easy for the beginning clinicians. Obviously, they should have a very good knowledge of the guided surgery, how is it planned and how it is fabricated. But yes, obviously it will become much more easier for the beginner clinicians. Now, how the surgical guide is made? First of all, we'll get a DICOM file from the CBCT and we'll get a intraoral scanner done, and we are going to extract a STL file from the intraoral scanning. If we do not have an intraoral scanner, we can get a model scanning also done and we can get the data from there. After merging both the data, we are going to send it to the lab. They are going to plan it. They are going to send the planning to us. We are going to evaluate it. if we feel like the diameter, length, distance from the anatomical structures, everything is good to go, we are going to give a thumbs up and we are going to print it. Once the planning printing is done, then we are going to go ahead with the surgical procedure using the Dentium guided surgery kit. Now, for the fabrication of the surgical guide, we need sleeves. So there are three methods by which we can put sleeves. One is the metal sleeve, which is there available in Dentium. One way is the open sleeve way and one is the non-sleeve way. Now, ideally, the sleeves which we use is the metal sleeve, which has open type and a closed type. So, the codes basically are FMS 49 and FOS 49. I'll show you the image also of that. Yes, so these are the two sleeves, this one and this one. So, what is the advantage of using a open sleeve? We are going to use an open sleeve in patients where there is reduced mouth opening and we feel like when I'm going to put my handpiece straight in the oral cavity, there can be a slight change in the orientation. So with the open sleeve, it will allow me to tilt the handpiece and tilt the drill slightly and then approach it at the desired position. There are also anchor pins which are used to stabilize the surgical guide. Now, anchor pins are of two types, 6 mm length and 10 mm length. Basically, these are used to stabilize the surgical guide. And how is it done? It needs drilling to stabilize the anchor pins. So, how is it done? With simple decortication, we just have to puncture the cortical plate and then we can simply screw it or simply push it inside tap it inside the bone. So in the cancellous bone, it is going to go simply like that, but in the cortical bone, we just have to drill. If it is a 6 mm, then we have to go halfway with a 6 mm drill. And if it is a 10 mm, we can go halfway or full way. If the bone is D1 quality, we can go full way also. Now, what are the typical positions of anchor pin holes? First is the buccal or labial flange area. That is the most common position in partially edentulous areas mainly. Distal extension areas, it basically prevents the rocking of the surgical guide. So wherever our implant, it is just mainly it is planned distal to the last implant placed. So we can, it is planned in those areas mainly. Third can be anterior region. It is going to provide a 3-point stability to the surgical guide. So that is why if the implants are being planned in the posterior region, we usually put an anchor pin in the anterior region, which is going to provide a 3-point stabilization. Palatal or lingual site. If the buccal or labial flange area is unapproachable, then we usually plan the anchor pin holes on the palatal or lingual site. Coming to the surgical drills which are there. So the guide drills are there with a diameter of 2.3. Then comes the 3.6 mm drills, 4.5. Tissue punches are there with a diameter of 3.5 and 4.5. Flat drills are there, and the fixture adapters, both bone level and tissue level, and as I told you, titanium opening, open and closed sleeve, and a ratchet. Now the offset of each drill is same, that is 9.3. So what is offset? Offset is the portion which is going to go inside the surgical guide. So till the drill, the portion of the drill which is going to stay outside, the non-working portion of the drill is called offset. Now this is the surgical guide kit. There are 6 mm, 8 mm, 10 mm and 12 mm drills of each diameter. This is the guide drill. Then 3.6 mm drill with the same length available. Then 4 mm diameter drills with 6, 8, 10, 12. And then coming to the 4.5 mm drills with 6, 8, 10 and 12 mm length drills available. There are 2 tissue punches available. in the diameter of 3.5 and 4.5. Two flat drills are there with a diameter of 3.5 and 4.5. As I showed you, there are two types of implant drivers. One is ratchet driven and one is handpiece driven, and this is the ratchet. Basically, a tissue punch of 3.5 mm is used in cases where I need to place an implant of 3.6 mm diameter, and a 4.5 mm tissue punch is used in cases where I need to place an implant of 4 or 4.5 mm diameter. There is also a flat drill available, which the usage of this flat drill is basically to flatten the irregular crest and to create a stable entry point, so that we have a similar platform created, so that our when we are going to insert our guide drill, it should not wobble, it should be quite stable inside. Coming to the drilling sequence. First, we are going to insert the flat drill, which is going to flatten the irregular crest. It is going to create a stable platform. Then we are going to increase the diameter of the drills by guide drill 3.6, 4, 4.5, whatever is the final diameter of my implant, which is planned, till the same length. So the initial drill has to be 6 mm. Then we are going to use the guide drill of 10 or 12 or 14 mm. Sorry, 8, 10 or 12 mm. Then we are going to introduce the 3.6. Then we are going to introduce the 4 mm drill. So it is a very, very precise and very, very fast way of placing an implant. Then we are going to use the same diameter drill, 4.5 mm drill of 6 mm length as a countersink drill, and then we are going to place the implant. The implant placement has to be done with a maximum speed of 50 rpm maximum. It should not exceed 50 rpm and at a torque of 35 Nm usually. And the drilling has to be done in the range of between 800 to 1200 rpm depending on the quality of bone. So first we are going to cut the tissue with the help of tissue punch. Then we are going to flatten the bone with the help of flat drill. Then we are going to insert the guide drill of 6 mm length just to mark the osteotomy. Then we are going to insert the drill of 10 mm length. Then if I'm going to place an implant of 10 mm, I'm going to use the sequence of 10 mm only. So 10 mm of my guide drill, then 10 mm of my 3.6, 10 mm of my 4, 10 mm of my 4.5. Then I'm going to use a 6 mm final drill. Then I'm going to use my 6 mm final drill as my countersink drill. And then I'm going to place my implant. After placement of implant, for the fabrication of prosthesis, we are going to put the scan abutment over it and we are going to scan it. Once the scanning procedure is complete, then we are going to choose the abutment. It can be a regular stock abutment or a customized abutment. That depends on the case, that depends on the tissue condition and the patient's occlusion. So whichever abutment we are going to select will be chosen for the fabrication of prosthesis. Once the crown is received from the lab, we are going to place it over the patient's mouth and we are going to cement or screw it. Now, thus in the sequencing, it is very, very important to place a 6 mm guide drill first and then place a 10 mm or a 12 mm guide drill after that. The role of this 6 mm guide drill is very, very important as it is going to establish a correct direction first. So if I'm not going to use a 6 mm guide drill, there is a chance that I might not be able to follow the same trajectory that I planned in the surgical guide planning phase. So that is why it is very, very important. Next is there is a chance, because the length of the drill of 10 or 12 is longer, so there is a chance that there is a risk of deflection or bending of the drills, which is not possible with the 6 as it is more rigid and stable. It prevents overheating as we are gradually increasing the length of the osteotomy. We are not increasing it in one go. So that is why we have to first prepare till 6 Once the position is confirmed, then we are going to increase the length. Better guide stability check. So after first 6 of osteotomy, we can confirm the guide seating. We can confirm that the sleeve is properly aligned or not. We can confirm whether my drilling path is correct or not. And we will also get to know that the patient's mouth opening is allowing the drill to go smoothly inside or not. Now coming to the digital components that will be used in the procedure, in the digital, if we are going with the digital workflow, digital prosthetic workflow, then what all digital components will be used? So first will be the scan healing abutment. So this is the scan abutment which can be used. It is available in two variants. Scan abutment is a metal or in peak. It is available in 3 diameters and several gingival heights. There is also a custom abutment for the fabrication of prosthesis. It is also available in 2 diameters and 2 gingival height. This is the titanium blank. It is a blank which is used for the fabrication of customized abutments. Basically, it can, if we want to plan a prosthesis in a more aesthetic manner, we can get a customized abutment made with the help of these TI blanks. These are the digital analogs. This one is used over with the multi-unit abutments, with the screw abutments, and this is over the this is the fixture level digital analog. These are the screw abutment components. This one is the scan comfort cap, which is of metal, whereas this one is of PEEK. So both are available. These are the titanium cylinders. So these are all multi-unit abutment level prosthetic components. This one will be used over the multi-unit, and this is the multi-unit level digital analog. So digital dentistry is no longer the future. It is the present. Dentium's digital guide kit helps converting the virtual planning into clinical reality with accuracy and confidence. So if I want to say about digital dentistry in 3 words, I will say it is predictable, precise, and efficient.